Welcome all to our third early adopter webinar. Maybe we'll wait a little bit for more folks to come on and then we'll start it on up. All right, ever impatient, I will get us started. I want to introduce myself and my colleagues first. We neglected to do that, doing a similar presentation yesterday. My name is Laura Miller. I'm a primary care internal medicine physician, and I work in the Quality and Population Health Management Division at DHCS, and I'm doing user and stakeholder engagement for the Population Health Management Service, now known as Medi-Cal Connect. I'll pass it to my colleague, Yoshi.
Hey everyone, my name is Yoshi Ling. I'm a family physician, medical consultant with Population Health Management Division, and I'm the project executive on Medi-Cal Connect. Sarah.
Good evening, everybody. I'm Sarah Lopez. I'm an emergency medicine physician, and I am the lead for the RSST risks stratification, segmentation, tiering workstream and the care management workstream. Back to you, Laura.
Thank you. All right, we'll get started with our next slide here. So we really want to welcome you. Thank you for taking the time to join us and hearing about what we're doing. And also, this is a time for conversation and questions. So please put questions in the Q&A. We will get to them as we can. And we also, if we cannot get to them within the context of the webinar, we'll certainly double back afterwards. So the goals today are to understand the goals, the functionality, and the release timeline for DHCS's Medi-Cal Connect. And as I noted, the initial name when this was all starting was the Population Health Management Service. It is now known as Medi-Cal Connect. As stated, we want to share and gather your feedback and talk about next steps for engagement. So please, we look forward to your feedback and certainly put questions in the chat. Next slide. So our agenda today is to review the visions, goals, and objectives for Medi-Cal Connect. We'll go over a user success story. These are always fun. And this flows from the first release of the service that's currently in use within DHCS. We'll tell you about our data sources. We'll give you a sense of our dashboards, see a few mock-ups. Sarah Lopez will lead us through a discussion of the risk segmentation, stratification, and tiering algorithm. And we'll also look at a preview of the portal. The portal is one way that members and other stakeholders can access the Medi-Cal Connect. And then we will wrap up. Let's go to the next slide. Next one, please. So the vision for Medi-Cal Connect is to provide a data-driven business solution that supports whole person care by integrating information from trusted partners to support population health functions and allow for multi-party data access and sharing. And to me, the key words in this vision statement are the whole person care. So many times we in medicine silo people into different buckets of physical health and behavioral health. They come to us whole, and our systems fragment them. So we're really wanting to reverse that narrative and pull in information sources from multiple sectors to really describe a whole person view of our Medi-Cal members. Another super important part is supporting population health, really being able to see the population and understand needs and allow for data sharing and access. Next slide. So Medi-Cal Connect has 4 primary goals supported by 10 core objectives. So the first one that you'll see here is member experience. Super important, really the core of Medi-Cal Connect. We want to be able to streamline access to services, help members navigate benefits. So many times people do not know what they are entitled to, and we really want to have impact there. We also want to be able to reduce service gaps, make sure that people get all the care to which they're entitled. The next goal is whole person care. We want to be able to really understand members' risks and unmet needs. And in this part flows in the risk segmentation, stratification, and tiering algorithm. Many algorithms that are used to stratify a population and separate out high risk and low risk, et cetera, are based primarily on medical claims data, not social data, not behavioral data. And we really want to be able to look at a person's whole context and risk stratify based on that. Another key feature of the algorithm is identifying unmet need, identifying underutilization, incredibly important. We want to be able to generate population level insights and be able to act on those trends and the disparities that we see. And of course, data informs policymaking. For the department, we want to be able to strengthen Medi-Cal oversight and monitoring, and certainly other stakeholders can use this for looking at their own populations, and of course, leveraging those insights into action. Next slide. So you may know about the Population Health Management Program and Medi-Cal Connect. This is an old but good slide that really discusses the relationship between the two. The Pop Health program is a core part of CalAIM, and it really focuses on Medi-Cal delivery systems to develop and maintain a whole system, person-centered strategy. The actors in the Pop Health program are primarily Medi-Cal managed care plans, and it launched in January of 2023, so now over 2 years ago. Medi-Cal Connect is built to support this policy. And as I noted, the service will integrate data from trusted sources, allow for multi-party data sharing and access. Medi-Cal Connect has a much broader group of stakeholders, like yourselves. It includes programs and infrastructures that extend way beyond Medi-Cal plans. The service is rolling out in 5 releases. As I noted, release 1 is within DHCS. Release 2 is within DHCS, coming up later this month. Release 3 is in July of this year for Medi-Cal plans, behavioral health plans, and state partners and agencies. And our hope is that by the end of 2025, we will release to health delivery partners, and then in 2026 to members. Next slide. This is just a nice illustration of all of the sectors that we want to pull from for Medi-Cal Connect, including health, physical health, behavioral health, social services, the carceral system, housing, pulling in enhanced care management information. So this just gives you a sense of the 360 view that we are working to build. Next slide. So we will now flow to a status update. I love this slide because it really is our work on one page. We are here right now with the green arrow in Q1 of 2025 with this webinar. Release 2 will be happening in just a little bit, and then you can see the releases as they roll out. So the gray dot, Q4 release 4, is for local county partners, health delivery partners, other Medi-Cal delivery systems, tribes and tribal partners. And then last, within 2026, we will release to members. Next slide. This is a view of the various functionalities that are built into the service. So release 1 has come out for DHCS, and there are 3 dashboards there. Whoops, did I make the slides go away? They have gone away for me. Would that I had it all memorized. Perhaps we can get a technical assist, and I will try to pull up the deck.
I don't think it was you, Laura.
Okay, that's good.
I can wing the timeline if you'd like.
Wing the timeline. Yes, somebody's deck went down. So wing the timeline, and I will try to pull up the deck.
So there's 5 releases. Laura mentioned them already. Release 1 already happened July 2024. Those are a small group of DHCS. We call them power users. So they got access to our initial 3 dashboards. Release 2 release 2 is happening later this month, which is going to be all our DHCS users. So we'll have several hundred people using the dashboards by the end of this month, along with a new dashboard. And then Release 3 is when all the Medi-Cal plans, so MCPs and behavioral health plans, will get access not only to these dashboards, but also access to the raw data and a longitudinal member record, which Sarah is going to show us in a little bit, as well as risk tiers from our statewide risk algorithm. And then Release 4 is for all of you, our health delivery partners. So that includes local county partners, ECM, health, and tribal partners. And so you all will have your own, depending on access and permissions, a lot of which is still being worked out. But so some of you would have access to these same dashboards. And then you would have access to these various care management tools that will be rolling out. And then release 5 is the member release for My Medi-Cal Connect. And we call it My Medi-Cal Connect for members. And that's going to enable these capabilities that Laura outlined previously. So that's in 2026. And then there'll be continuous quarter releases. I don't know what's happening with our slides. I can try to share my version.
That would be awesome. I was looking for mine and failing. If you can share your version, that's great, Yoshi. It will come to me soon. Wonderful. Yep. So Yoshi took us through the release roadmap nicely, and we'll go to you. Can you move it to slide 13? Wonderful. So this is just a brief overview of the types of engagements that we are doing. Gorgeous. This is an example of the webinars that we are doing and listening sessions that we're doing with all sectors. We've also had small group discussions, and for members, you can see there is focus with various different modalities, including tours of Medi-Cal offices, which we did earlier last year, as well as focus groups and surveys coming up. Let's move to the next, and Great. I'll take this one as well. So when we did our lobby tours, we learned a great deal. We spoke with both members in the lobbies waiting as well as county eligibility staff. And we had many takeaway messages from that. Members need guidance on next steps after eligibility. They need ease in navigating the Medi-Cal system. It's definitely challenging. It's a complicated system. Members would like the ability to update their contact and demographic information, and we know that that is a pain point for plans as well. They absolutely would like support locating a provider or a service. Once people get Medi-Cal, they of course have to pick a plan and then pick a provider. And there are many benefits within Medi-Cal that a lot of people don't know they are entitled to. And then members are definitely worried about data security, which makes all good sense in the current age. So these are things that we've learned, and as we build out the service, we'll be looking to include these elements, deliver on some of these desires. Next slide.
All right. Thanks, Laura. This is me. Actually, before I go there, I just wanted to pause and emphasize how this is a really game-changing tool. No other state in the country has done this, bringing this amount of data together from diverse sources for the benefit of our Medi-Cal members. And so I'm about to show you something that one of our medical consultants did with our data that's we have never been able to do before. Here we go. So this is not his real picture or his real name, but he works in our Quality Health Equity Division. And he wanted to look at various quality measures by county. So he was in Medi-Cal Connect looking at our dashboards, looking at, it was pediatric lead screening and immunization rates. And he was looking at, we have a heat map, and he saw Imperial County looks like they're doing really well with lead screening. And so he actually reached out to Imperial County to figure out what's their secret sauce, what are they doing that is resulting in these improved, well, I should say, compared to other counties, higher levels of lead screening and childhood immunization. So I believe the update, they had that meeting, and now he's working on how to perhaps share best practices. And then another example was he was similarly looking at the heat map and finding counties where there are larger disparities in childhood vaccinations among Black African American children. And so he followed up with MCPs in a regional collaborative meeting to begin talking about how can they address the disparities in those counties. And I think the update there is they're beginning to talk with CBOs, local CBOs that can help address the immunization disparity. So really exciting applications of data that we've never been able to pull together before, and just wanted to share that. All right, so you may be interested in what data will be available. So here we go. So here's what will definitely be available as of release 3, which means by the time it gets to all of you, our healthcare and service delivery partners, all this will also be available to you. So all Medi-Cal claims data, also known as this APCD CDL file, this is it's comprehensive claim data, our services rendered, billing codes, diagnoses, and other claims related information. So if you're a ECM provider, for example, and you've never had a list of diagnoses and services, like where has this patient been seen for what diagnosis, you will now have that. Supplemental eligibility file, the second bucket, this is data that enriches core eligibility data. It adds demographic and contact information. There's some more details below there. And then we're also going to have new data that's generated by or within Medi-Cal Connect. So these are things like member flags. So you'll be able to see who's likely eligible for ECM or likely eligible for community supports. This will include the risk algorithm risk tiers, showing who is at highest risk among a given population, which will include analysis incorporating underutilization as part of that risk tier. Okay, these will maybe be available by release 3 and almost certainly by release 4. So the first bucket here, enhanced care management and community supports, a JSON file, which is just a file format. But I'll jump down below. This is going to have member enrollment details, the ECM provider contact information, the community support organization information, services provided to members under ECM CS. So we anticipate this will be helpful to many of you. The second bucket, this primary care provider assignment file. So this is going to show who the member's PCP is and their contact information. Then there's the provider and organization data. This is also known as the 274 file. This is going to be detailed data on the types of providers and the organizations involved in taking care of a specific member, including care managers. So you can imagine as a care manager, I won't spoil it. I won't take Sarah's thunder away. She'll show you. Also, CalFresh data, hopefully by release 4, we'll have CalFresh data, IHSS data, and WIC data, which is my personal favorite, and very excited that we'll be able to share that. I also wanted to emphasize that our plan is that you'll have 2 ways of accessing this data. So one is in the dashboards, and then 2 would be to provide member level data for your members. And again, that's what Sarah's going to show more in the longitudinal member record. All right, dashboard update. So some of you have heard about these before. The first 3 on the left are the dashboards that went live for us back in July. There's a condition prevalence dashboard, which is more or less self-explanatory. There's a quality measures dashboard, which is allowing us to, that's what I used in the example, to analyze quality of performance across the state. I have a question here that I'll come back to in a second. We have a health equity dashboard that allows for very granular views into disparities for all kinds of metrics. And then we will have a new RSST dashboard. So that's going to be a visualization of the highest risk members. And we also went live with a care management demographics dashboard. So we can see what are the demographics of folks receiving ECM or CS as an example. So my question for you all, and you can put an answer in the chat, is would it be valuable to be able to pull a list of members who haven't met a specific quality measure? So an example, members who haven't followed up after an ED visit for mental illness. This could either be some kind of drill down function in the dashboard, but more likely would be something you could pull from raw data. Actually, I shouldn't say more likely. Those would be the two different methods that we could employ. All right, Janine says yes, definitely. Anybody, any others? Chime in. Would you want to be able to pull a list of folks who haven't followed up after ED visit? Or is that something you already somehow have access to? Like if you work with an amazing MCP, are they giving you that data? Not clear if MCPs would generally have that data. Yeah, data lag, good question, or a good point. So we have a couple months of lag on claims data, which makes it tricky to use Medi-Cal Connect for, I would say, true care management because of that claims lag. But we hope that in many ways it'll still be helpful. Yeah, if we can't get it in 7 days. So here's an example of what we're thinking is if you were able to pull this list, then you could see historically who, you could historically see which members or a list of names of members who are having trouble, right? Even though you wouldn't be able to follow up in that 7-day window. Okay, feel free to continue weighing in, and then I'm going to keep moving here and hand it over to Sarah.
All right.
Dr. Lopez.
Thank you. Are you guys able to hear me?
Yep.
Perfect. So I'm going to be talking about risk stratification, segmentation, and tiering, or RSST. This is something that all managed care plans are actually required to do and already doing in some shape or form, using stratifying individuals or segmenting individuals, different members, and then tiering them, right, in terms of high risk, medium risk, and low risk. And one of the things is that there's a different definition across the board. And what we're doing at the state is that we're actually going to be running all Medi-Cal members, right, through this RSST algorithm, which is basically an AI generated supported algorithm that has a variety of predictors to basically predict who is at high risk for adverse outcomes, and adverse outcomes in physical health and adverse outcomes in behavioral health. But also something that we're doing that is very unique is who is high risk in adverse outcome or in underutilization of resources, both in physical and behavioral health. And then we have a social risk, right? Those who have high risk for social risk outcomes. And so these are basically this algorithm, this RSST is going to be implemented, and each plan is going to then have a set of members that are going to be flagged. Next.
Oh, sorry,
like,
Sarah. I was responding to the chat.
no
There you go.
problem. And so one of the things that we're going to be doing is once this algorithm kind of generates, we're going to tier those individuals, and you will have a certain percentage of individuals in your plan that are flagged high risk, medium rising risk, and low risk. And from those that are high risk, those individuals are going to need an assessment of some form to be able to screen them and provide support. And the thing that's going to be really nice is that it's going to be standardized across the board, that we're going to have a definition for what high risk really means that's going to be implemented across the board. And this is actually playing along, this is part of the QPHM policy guide in terms of, like, we've been talking about having a standardized RSST algorithm that's going to be used, and this is it. Next. Now, why is that important, right? Like, then what do you do? How do you do this? So that's actually where we end up having these, what's called this longitudinal member record, right, in the care management portal. Next. And what happens is you can see here, Nia Johnson, right? You can see at the top is going to have her risk basically identified there for adverse events, either in physical or behavioral health, underutilization in physical or behavioral health, or social risk, right? So it's going to be flagging whether, she's rising risk or low risk or high risk. And this card here basically gives you the overview. You could see her member ID, her date of birth, her contact information, what language she speaks. You can see here also that it'll have her health status, what chronic conditions she has, current medications she's taking, unmet measures, program eligibility. You'll also see the primary care provider that has been, taking care of her, and the last visit that this individual, this member, went to her primary, along with utilization information. And you can actually click into each one of these to take you deeper and open it up, right? So we're going to click in. And here you could see that we clicked under diagnosis summary. And for diagnosis summary, you can see that we are looking at chronic diagnoses, right? Or you could also look at all diagnoses. And you can filter, you can basically select either looking at 6 months, 12 months, or 24 months. And then there's all these filters, this ability to filter by diagnoses, total visits, the provider that's providing these services, the specialty, and the location. And let's say we go into asthma, right? So we have asthma, 6 total visits, and we go in deeper, we click view, and it'll take you to the history here. And so for Nia, she has had a visit for her asthma on 8/1/24 by Dr. James Smith in the office to treat for asthma exacerbation. She also has had another visit on 5/22/24 by Dr. Linda Nguyen as a telehealth provider to treat her for this a different exacerbation. And then on 2/18/24 by Dr. Robert Kim at Kaiser for urgent care, right? So you can actually then get a sense of where is this individual getting their care and support for these chronic conditions? How often are they getting? And this dashboard basically is updating and giving you data based on what time frame you have selected. Next. Now, this is actually one of my favorite tabs, because as a care manager, right, you want to know who's participating in the care. And actually, this is something that we're going to be asking, the managed care plans to submit, like, who is the complex care manager, right? Who is this complex care manager for individuals and members that are receiving these types of services? And who is the ECM provider? And the reason we're asking for this is that we're going to have a care team tab where you're able to see who is the primary care provider that this individual is assigned to, right? Their PCP, what's that contact information? When was the first visit with this provider, and when is the most recent visit with this provider, right? Then you also have your care manager in the middle, Emily here. Emily Harris is the complex care manager. This is Emily's work phone number, work email, and the location, the physical location she's at, right? So me, a care manager, let's say in behavioral health, right, can take a look at this and say like, oh, that's who's taking care of Nia at the managed care plan, right? And so I'm able to then contact Emily and say, hey, I'm taking care of this same patient, or I need to send an email and contact. And then the final tab is actually for the individual that has the best or the most frequent relationship. Oh, can we go back? Yeah, has the most frequent relationship with the individual. And that's what this one is. And this can be an LCSW. It could be the specialist, right? Sometimes if you are, you have diabetes or you have asthma, your pulmonologist, your endocrinologist is really the person that you're seeing the most. And so that's actually when you click in, you can see how many times that individual has seen all these different, has seen this particular provider, right? So Dr. Smith, who's the pulmonologist, has been seen this many times for this condition. Next. Okay, and I will hand it over to you, Yoshi.
All right. Wow, we zoomed through that. Great job, team.
We did.
If we went too fast, now we have a lot of time to go back. We were concerned, we wanted to give you plenty of time to ask questions at the end, so we were kind of purposely trying to go at a brisk pace. So let me, feel free to put questions in the chat, and then we'll come back to those. We'll try to figure out if we can unmute folks. We've in the background definitely having some tech challenges. But this is a poll that we wanted to ask about your wishes, desires for care management functions. So go ahead and pull out your phones and can scan that QR code, or if you want to type that URL into a browser, you can do it that way as well. So 4 questions here about care plans. First one is, would you like to create or upload care plans in Medi-Cal Connect? Yes or no? And I guess the kind of context here is, we know that all of you who are ECM providers, for example, you have your system already that you use to document care plans and perhaps you have a way to share care plans with other partners. But we're wondering, would you want to enter it in Medi-Cal, enter it in discrete field in Medi-Cal Connect, or upload a care plan? Second question, would it be valuable to see care plans from care management providers or other Medi-Cal plans? So for example, you can think of a member who's moved to a new county. Would you want to be able to see care plans from that other county? The third question, if you could, would you log into the portal to review care plans from other care team members? That kind of overlaps with prior questions. And then finally, if you're not connected to an HIE or a QHIO, would it be valuable to use Medi-Cal Connect to upload and review care plans? And then we'll take a look at the poll results. And, if I was going to say, the spoiler is yesterday, we had a webinar with the plans, and the Medi-Cal plan said, yes, we think, or at least there was, several that said, yes, we think this would be helpful. So that nudges us to go ahead and build this functionality. That's kind of the spoiler. So we will almost for certainly build this. Okay. And then our final slide is just any comments or questions. So let's see. Yeah, go ahead, Laura.
I got a quick note from our tech team that if folks raise their hands, the team will be able to unmute them so we can actually have real human conversation.
So we'll look for hands.
I know you're answering questions in the chat, but there were a few questions about access and permissions, if you want to maybe verbalize the response to that one.
Yeah, so let's see. There was one question about CCS and SMHS data. Yes, that any data that comes to DHCS, we are working on getting released. We're not asking for data that doesn't, well, it's data that we already have permission to use. The access and permissions work that we are doing is really figuring out all of those combinations where the person logging in has the right to see the information. We know it's a very thorny issue and we're working on it diligently.
It is being discussed by our legal team today. Looking at, is there a plan to allow local MCAH departments and all 6?
I can speak, well, wait, there's the plans are asking ECM providers to upload care plans. This would not be, at this point, be required. I should actually probably let Sarah speak to this, but it is an option, but not a mandate.
I do want to say that, one of the things that we are working through this process of like, how are we going to be collecting a lot of the assessments that are being done on members? And that information will be shared with all of you in subsequent like information connections and communications.
You have a question, Sabra. You can, I think, unmute yourself now.
Yeah, Sabra.
Sure. Well, I would just be piggybacking on what Amy Anderson said, in that one of the big pushes for us is to minimize administrative cost and duplication. So it would be wonderful to see the care plans but having to upload them to multiple sites is a little bit problematic. And then the other piece is just whatever the lag time is on getting information and being able to access it. We have a lot of questions about the source of truth, from our health centers. Is it the plans data? Is it the IPA's data? And now we'll have state data. And so lots of times they just end up getting mad that those records don't match. So trying to have that source of truth, and usually the ones that are the most real time are where they go to, unless they're looking for something historical. So I guess it just depends on how things are billed, because you may want to go in and look at a historic care plan for a patient, that they had when this issue flared 2 years ago or something. But in terms of that real working document, it really seems to be most generated by whoever has the most real time.
Mm-hmm. Yeah, hear you on the source of truth issue. And we're very aware of not wanting to create a double documentation, triple documentation mandate. I've lived in the ECM world, as has Sarah, and we know we do not want in any way to increase administrative burden at all.
We are having these conversations, and so we will be coming out with more communication about this. But part of the thing that's interesting is because RSST is being standardized, there will be a level of communication about like what the next steps are when you have someone that is flagged as high risk.
I'm gonna start looking at these chat questions from the bottom up, because I know either of you guys may have replied. And am I correct in thinking the slides are down, right? Looks like
No, the slides are still visible. We could
Oh,
actually,
okay, interesting.
at least they're visible for me.
Yeah, Teams webinar works differently than regular Teams. Okay, looking at your questions. Yes, Meredith. Double work.
There was an EHR question. Are we integrating
Right.
into EHR? And the sad answer is no. We know that's the perfect world, but we're not at that level at this point.
We would love to do that eventually, especially as data exchange framework and QHIOs become, more commonplace. And so I think, Mika, someday we hope to be able to do that, but not in the initial releases.
Yeah.
There isn't a space to, this is Amy Anderson, is this different? There isn't a space to add this to your survey, but some plans are asking ECM providers to be uploading care plans into a separate system. Oh, that's the one you answered. Okay.
I answered that one, although, yeah.
That's another, I see Sarah's expression. This is another future state that we would love to do, but it just wasn't, realistic or doable within our limited resources to replace all of that infrastructure. CCS and SMO. Did you address
I did that
Yeah.
one.
Yeah.
There's a question from Sabra at the bottom is, can there be a feedback loop for when we find data that is incorrect? Plan data has its challenges. Yes, we know that that's an issue. We're working on building those workflows. Absolutely.
Yep. All right, let's look at the, whoa, split down the middle. Interesting. Okay. Do we have our sample size, Sophie? Do we know how many people responded? Our N? 11. Only 11 guys? There were like 60
We're
people.
not that scary.
Let's here, let me put up the QR code one more time. We would love for you to respond to the survey there. I'll keep that up.
Okay. And somebody's on their mobile, so can't do the QR code. I fully understand.
Oh, and I'm getting confused. Sophie is actually sharing screen, not me.
She is sharing screen, yeah.
Thank you, Sophie.
Are we able to share a link that's not a QR code? Is that the poll?
That's the poll, EV. Yeah.
Okay.
Oh yeah, I can here. Let me see if I can do
The-
that. pollev.com/Vincent. So 800. Although that's not a hyperlink. Okay, let me do you one better, Sabra. I'm going to see if I can turn it into a hyperlink. This is why I went to medical school, everybody.
Exactly.
And we also have another hand raised, Amy Anderson.
Yeah.
You should be able to unmute.
Yeah, I just wanted to piggyback on another one of the questions about the ICD-10 codes that are being used, and sort of the depth that you're going to be pulling for those. We worked really hard with like our local ERs with some of the social drivers of health ICD-10 codes and trying to put them up at a certain level so they could get pulled into data. And I'm just wondering, are you going to pull all the ICD-10s that come through in an ER visit, or is it the top 5? How is that information coming to you? That makes sense.
It doesn't. I'm actually I think, Sarah, can you answer that one?
Yeah, so we're pulling all codes. So all claims are going to be coming in and being filtered for each individual member. So we're actually pulling all claims that are coming to DHCS. We're using those. So
Right.
anything that comes to us, yeah.
So this is where it gets tricky, and this is where I'm a nurse and I get
Yeah.
myself in trouble with claims people. So if there's any claims people on this call, just tell me I'm dumb and it's totally fine. My understanding is that in the claim you get the top like 5 codes, and
So
you don't get them all pulled. And that may be incorrect information that I've been living with for 15 years, or it may have been correct 15 years ago and no longer correct now. Um, but it's my understanding that not all of the ICD-10s in an ER visit will get pulled into a claim. And I don't know if that's correct or not, but I'm curious if that is perhaps misinformation that I have, so that we're not losing some of that social coding.
information. So
Yeah.
that's a good question. My assumption is that it's whatever your organization, so it's whatever the claims that are sent from the provider to the managed care plan and from the managed care plan up to us. That's the information we're getting. Now, if at the managed care level, you're only sending the first 5, it's basically whatever the managed care plans are giving to us. That's what we're capturing. And so then it might be that each one is different. And if there's a claims person here, like I don't fully know that, but I do know that every claim that comes into DHCS is being used to fill in and support the both the algorithm for the member, for the risk tiering, and then whatever we put in the claims, whatever we put it for, like the claims history. And one of the things that we are doing, it's, for diagnoses, we're doing, it's not just like the first diagnosis, but it's like discharge diagnoses if they get admitted into the hospital. It's like their discharge diagnoses, which has been validated, right? So those are the ones that we actually end up putting in. So it's not just like the first top 3.
And Sabra sounds very knowledgeable about claims. Put in some additional information there in the chat. I also realized some people were putting questions in the Q&A button,
That's
but
true.
I would appreciate if just put it in the chat, the regular chat, because it's getting difficult to keep track of which questions we've answered.
And also, we are coming to the end of our time. I think we got a lot of them, Yoshi. And
Yeah.
certainly put questions anywhere. We will find them and get back to you if we haven't answered on the call. Yeah, Mika, can you unmute?
Yes. Hi, I had a quick thank you for the presentation and sharing all of the slides after. Quick question on just more regular touch points with DHCS. I know at Path Collaboratives, for example, it's usually the MCPs. So for CS ECM providers, just curious how we could share more feedback as to what we're seeing and data monitoring, evaluation, quality measures, and so on.
So are you an ECM provider, Mika?
Yes, for the birth equity.
Oh, awesome. Thank you. One way to do that is with the ECM, the CalAIM ECM ILOS inbox. That is a mouthful. I can put it in the chat. That's absolutely one way to let us know what's going on. Also, we have consistent touch with the CPI facilitators. So I don't know if you're aware of the CPI facilitators in your area, but that's another way to raise your voice. I'll put the email in I guess I'm in the regular chat. Does that help, or does it not enough?
Yeah, I guess. Yeah, no, that is helpful. I was just curious whether there's a forum for direct, like with ECM providers and DHCS.
It's it's the box, it's that email address, and then through CPIs for sure. But
Okay.
certainly interested in, in your experience and what's going on.
Mm-hmm.
Absolutely.
Perfect. Thank you.
Thank you. We we are about at time. I really want to thank everybody for your engagement, your participation. This is the last planned webinar that we have, but we will be doing communications going forward, and you're certainly reach out, and we will try to get you answers. We will send the deck as well as answers to questions in the chat. Well, thank you so much.
Yeah, thanks everyone. Really appreciate your input. And we thank you for your service to our members. We're really excited for you to get your hands on this this game-changing tool for our members across the state. Thanks everyone. Take care.
Thank you. Bye.